I would like to introduce the members of the committee. First of all, our distinguished guests from Romania, Marcel Tancel, from Cluj, Kolozsvár, Klausenburg. He's a senior professor and lead for gastroenterology at University Iuliu Hatziaganu. Okay. We also have here Octavian Andronic, who is a surgeon and senior lecturer at Bucharest. We have here Zoltán Zádori, who is a pharmacologist and an associate professor. Tibor Gyökeres, who is the president of the Hungarian Society of Gastroenterology and also the lead for one of the largest gastroenterology units in Budapest. Patricia Sarlos. I should have started with her, ladies first. She is one of the distinguished associate professors in gastroenterology from University of Pécs, and I would like to introduce you the chair of the committee, Lajos Bogár, who is a professor in anesthesiology and intensive care also from University of Pécs. So the house rule is that we will listen to the presentation, the defense of the thesis from the candidates. The committee will retire. Please do not leave the room when the committee retires. You can chat, you can stand up, but don't leave the room. And then the committee will come back and announce the assessment of the candidates.
It's a great pleasure for me to introduce my PhD student, Anett Rancz, who was born and raised in Kézdivásárhely, Romania. She graduated from Nagy Mózes High School and continued her studies at the Faculty of Medicine, University of Medicine, Pharmacy, Science and Technology of Marosvásárhely, Târgu-Mureș. During her studies, she participated in Erasmus programs in France and across Hungary in multiple hospitals. She also won the first prize at the 28th Transylvanian Scientific Students' Conference at the pediatric section with her work entitled Investigating the Vaccination Status of the Pediatric Population in Kézdivásárhely. After graduation, she started her PhD studies under my supervision at the Center for Translational Medicine, Semmelweis University, benefiting also from a 12-month fellowship program provided by the Moll Foundation for the community. Her topic is focusing on the risk factors of microscopic colitis and one of the extraintestinal manifestations of the disease. In her second year, she joined the CTM as a scientific methodology supervisor, mentoring currently 17 younger students. She is the current second-year PhD students coordinator and was the former meta-analyses deputy coordinator. In 2024, she became an assistant lecturer at the CTM. Anett is an open-minded person who enjoys working with others and thrives in the collaborative environment of the CTM. She is a dedicated, hardworking person who have broadened her perspective and strengthened her professional and soft skills throughout the past years. Her honesty and humbleness serve her greatly through her career. Thank you.
Dear esteemed committee, dear audience, good morning. My name is Anett Rancz, and I would like to present my PhD work entitled The Invisible Presence of Microscopic Colitis. I'm an assistant lecturer and a scientific methodology expert at the Center for Translational Medicine. I am grateful to my supervisor, Emese Mihály, and to my scientific methodology supervisor, Brigitta Teutsch, as well as to everyone who contributed to the success of this work. In my vision, patients with microscopic colitis get an early diagnosis. To reach this, my mission is to provide professional knowledge about risk factors associated with this disease. To achieve my vision, I've set two specific goals with my team. The first is to determine if MC is a risk factor for low bone density, and in the second, we investigated the risk factors associated with microscopic colitis. Both projects have been conducted via the methodologies of systematic reviews and meta-analyses. Why is this topic important? In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person years, and it's still rising in Western countries. However, due to Emese's primarily histological appearance, it may take years to diagnose, since it requires not only well-trained general practitioners, but also gastroenterologists with high endoscopy expertise and up-to-date pathologists. Therefore, the number of cases is considered to be underestimated. So what is the problem with the late diagnosis? Emese is characterized by chronic watery diarrhea, stool leakage, and nightly defecations, which not only limit a person's physical abilities, but can also be a psychological and emotional burden on the patient, and can limit them on their social and occupational maintenance. That all leads to low quality of life. So how can both patients and practitioners benefit from this work? First, determining Emese's clinical risk factors could help the clinicians to provide an early diagnosis for the disease. It could ameliorate the patient's psychological welfare impairment, anxiety, and depression, and ease their gastrointestinal symptoms by applying the correct therapy. Second, determining if Emese's extraintestinal manifestations include low bone density. It could help us to screen the patients at the moment of diagnosis and could help to potentially prevent the osteopenia. So now I would like to present how we approached these aspects of this disease in my first project entitled Microscopic Colitis is a Risk Factor for Low Bone Density. In this project, we investigated the relationship of these two diseases. Emese's symptoms contribute to weight loss and mineral deficiencies like calcium and vitamin D, and urge patients keeping a narrow diet, worsening the bone health maintenance via poor mineral intake. Moreover, both diseases are more frequent in elderly women. These women in postmenopausal state can receive hormonal substitution therapy, which in turn can cause microscopic colitis. Furthermore, the gold standard therapy of Emese is the locally acting steroid budesonide, which has been implicated as a detrimental factor being for low bone density. Therefore, our aim was to scrutinize if Emese is a risk factor in the development of low bone density. What was our clinical question? Is Emese a risk factor for developing bone mineral decrease? We applied two frameworks, the PECO and the COCOPOP, hypothesizing that Emese may lead to secondary osteoporosis. We made our systematic search on the 16th of October 2021 in 5 databases and got around 3,000 hits. We applied a search key constructed from 2 main parts. The first part contained Emese and its subtypes, while in the second part we included osteoporosis and the synonyms of it. The number of included studies in this review was 4. Our first outcome was if Emese is a risk factor for low bone density. We investigated Emese patients compared to age and sex-matched controls with a 37% moderate heterogeneity, presumably due to the Lorenzi study, which has a cross-sectional study design with the youngest and the smallest number of patients. Our overall measurement, the odds ratio was 2.13, meaning that microscopic colitis doubles the odds of low bone density. When we investigated if Emese is a risk factor separately for osteopenia and osteoporosis, we found that the odds of osteopenia were 2.4 times higher. However, in the case of osteoporosis, we have only seen a slight increase in the odds ratios, but this relationship was not statistically significant. In our proportional analysis, we investigated the bone mineral density reduction among Emese patients. 2/3 of the patients had low bone density, the overall proportion being 0.68 with 75% considerable heterogeneity, presumably due to the Greenberg Conference abstract, which had the oldest population. In the case of osteopenia, we detected an overall proportion of 0.51, and in the case of osteoporosis, a 0.11 proportion, which means that 1 in 10 MC patients had osteopenia. The strength of this study is that this is the first comprehensive analysis regarding the relationship between these diseases. All included studies used DEXA to measure bone mineral density, and we applied a rigorous methodology. On the other hand, the number of included studies was low, and they had different study designs. The patient population included in the studies was also a bit low, and there was a female predominance among these patients. Furthermore, there was not enough data to pool adjusted odds ratios. In conclusion, our data suggests screening MC patients for bone mineral density at the moment of diagnosis. Based on our findings, we can recommend lifestyle and dietary changes, calcium and vitamin D supplementation in the case of osteopenia, and we can also recommend impact exercise combined with resistance training, because it was shown that this is best fit for pre- and postmenopausal women to maintain their bone mineral health. Regarding implications for research, further prospective studies are needed, and we would like to highlight the need for international and national registries to assess the bone mineral density of MC patients. As we suspect that MC is an underdiagnosed disease, that might be one reason for having small sample sizes in our first investigation. Besides this, many of the included studies lacked confounding factors, which might be the risk factors. Therefore, our second study is entitled Risk Factors for Microscopic Colitis. Here, to give a bit more insight about the disease, its etiology is unclear but suspected to be multifactorial, like in genetically predisposed individuals, certain luminal factors via the impaired mucosal barrier enter to the bowel wall and initiate autoimmune responses. A multitude of data is available regarding the risk factors of this disease. However, in the literature, these relationships were reported with contradictory information and with certain limitations. Therefore, our aim was to assess the risk factors for MC in adult patients. We applied a PECO framework investigating unchangeable, like age and gender, and changeable lifestyle risk and medication risk factors for MC. And we hypothesize that the odds of developing MC are higher in the presence of the risk factor. We updated our systematic search on the 6th of January in 2025, searching in 3 databases, and got around 9,000 hits, applying the search key containing only MC and its subtypes. The number of included studies in the meta-analysis was 45. We grouped our analysis based on the distinction of 2 different control groups, having histologically verified and non-verified random controls due to MC's primarily histological diagnosis. Now I will focus on and present the most important findings with the comparison of MC patients with their histological controls, considering that these are the most relevant and most to the truth. The overall measurement can be seen at the figure space. In our first analysis, we investigated the mean age difference of MC patients and their histological controls, and we found that MC patients are older with a mean age of 5.93, almost 6 years. In the case of the investigation of female sex, if it's a risk factor for MC, we found a statistically significant result with an odds ratio of 1.48. In the case of smoking, nor in the case of past smoking or in the case of current smoking, we could not detect a significant association when MC patients were compared to histologically verified controls. When we did our search, we have found many medications implicated in the relationship of MC. However, now I will show you the most important ones. First, the proton pump inhibitors were found not to be significantly associated with MC. The odds ratio is increased, however, the confidence interval lower limit is not above 1. Second, non-steroidal anti-inflammatory drugs were found to be significantly associated with this disease, with an odds increase of 2.5 times. Third in the row, selective serotonin reuptake inhibitors turned out not to increase significantly the odds for MC. And lastly, the statins doubled the odds for MC with an odds ratio of 2.15. The strength of this study is that we applied a broad search key, finding a high number of studies, and we analyzed the huge patient data. And we could make a distinction between the two control groups, like the histologically verified and non-verified random controls. And we applied a rigorous methodology. On the other hand, we included many case control studies, and the definition of the risk factors varied across these studies, and we lacked follow-up data. Our data confirm that older age, female sex, NSAID and statin use are clinically relevant and statistically significant risk factors for MC. Based on our findings, we would like to raise even more awareness of this disease among all practitioners, especially if potential risk factors accumulate, and we would like to emphasize the need for interdisciplinary collaborations to get an early diagnosis for these patients. Regarding implications for research, further incidence studies are needed to assess the medication's dose, time, and frequency measurement, and we would like to highlight the need for international and national registries. Regarding future perspectives, there is a need to investigate further the etiopathogenesis of this disease, its relationship with the other diseases, the effects of biologics and immune modulators on it, and the microbiome changes, highlighting the need for long-term international registries. Now I would like to reflect on the many great opportunities that I get to present my work at international and national conferences, like at the annual group meeting of the European Microscopic Colitis group and at the United European Gastroenterology Week at Copenhagen. And I had the honor to present my work at the seminar lecture of the Chinese University of Hong Kong this March via the Translational European Asian Network. Throughout my PhD years, I was a methodology supervisor for many students working at the different fields, and I had the honor to be the year coordinator of the first year students in the academic year of 2024 and 25, and I am continuing to work with them in this year as well. I have delivered soft skills and hard skills throughout my PhD years as well. And I have contributed to the publication of 11 papers with a cumulative impact factor above 50 until the publishing of this presentation. And I have 2 projects that are related to my topic. Now I would like to express my sincere gratitude to my supervisor and mentor, Emese Mihály, and to my scientific methodology supervisor, Brigitta Teutsch, to the leaders of CTM, Péter Hegyi and Gábor Varga, to my dear colleagues, Maria Neng and Mahmoud Obeidet, to our statisticians, Daniel Sándor-Veres and Anna Walter, and I would like to offer this work to my family, who supported me throughout my whole life to follow my dreams and instincts, and I owe my respect to my friends, to the secretariat, to the event organizers, to the whole Ferrari team, and I would like to close my presentation with the words of Beverly Sills, that there are no shortcuts to any place worth going. Thank you.
for her excellent presentation on a very important medical problem, the microscopic colitis. I have the feeling that the more we know on a topic, the more question arises, as you also indicated at the end of your talk, which is now open for discussion. First of all, for the evaluation committee, I would like to ask Professor Marcel Tantu to present his view and questions.
Thank you very much, and congratulations. We are coming from the same part of the world, and yes, it's interesting because microscopic colitis, it's something which we don't use very often in our diagnosis, and I don't think we really diagnose it quite clearly. For the first topic, my question is, do you think that osteopenia, maybe in these studies, and osteoporosis is related to the malabsorption because of the diarrhea, or it's together in the same disease going to microscopic and to this? Do you feel that there were some hints on that or not?
Thank you for the question. As you mentioned that we do not usually use as a diagnosis this microscopic colitis because it is really underdiagnosed. That's why we believe that there have been so few cases on this topic. Regarding the osteopenia and osteoporosis appearance in these patients, we suspect that it might be in relationship to this disease. However, unfortunately, the included studies were not prospectively following these patients. There was only one study, which was a prospective investigation regarding these patients. And in that case, we can tell that at what point the osteopenia or osteoporosis appeared in these cases. However, in the other three studies, they have been retrospective observational studies, or there was also a conference abstract, meaning that we get only a glimpse of like a cross-sectional design regarding these patients, so we cannot really tell that was there the diarrhea previously, which could lead to the malabsorption of the minerals and the correct nutrition, or it might be a consequence of this disease. Furthermore, since it is late diagnosed, it is more prone to be in elderly females who are more in danger, or let's say these are also risk factors for low bone density.
And maybe we have to screen them for microscopic colitis if we have low bone density.
That's a very good suggestion. Yes, thank you. In the case if there are clinical symptoms, so like chronic watery diarrhea in the case of the patients, the screening of microscopic colitis is definitely suggested. Especially that in these cases there might be other reasons as well behind the chronic diarrhea, but a differential diagnosis is very important.
Thank you. Regarding the second study, because I'm following more IBDs and I'm very attentive to the frontier between Romania and Hungary, and that's a sharp difference between incidence of IBDs in Hungary, which is increased, and in our region, which is close, not all the Romania, which is a little bit lower. Do you have some data about microscopic colitis in Hungary and in our part of the, we are 100 kilometers distance?
Thank you for the question. Based on my knowledge, yes, here really the number of IBD patients are rising. And a couple of 10 years ago, microscopic colitis was also considered to be the inflammatory bowel disease.
That's why.
Nowadays, I can tell that there are few number of patients diagnosed in Hungary as well, but that might be also the unawareness, I would say, of the clinicians regarding this disease, especially as you also mentioned that we do not usually use this diagnosis. And if the gastroenterologists, the endoscopists do not see any change on the mucosa, it might happen that they do not take biopsies, which will not get us to the diagnosis of microscopic colitis, because in more than 90% of the cases, they are only visible on histological side.
We don't follow all the time the protocols.
That's right. And regarding Romania, what I can tell is that I have barely heard about this disease.
Yes.
Only in our material that is mainly regarded for the students, for those medical students who would like to make their residency there. Yeah. And I know for sure that Kumar book contains microscopic colitis, because I have checked myself as well that what is the literature on it in Romania.
I will continue a little bit in this field, because of course microscopic colitis and IBD maybe are related. And because also the treatments you use, do you have some insights of the microbiota studies? Because there are, in IBD, while we have some bugs or some bacteria which are pro or do you find something about microscopic colitis in this? Do you study it a little bit, or only these risk factors? Do you relate them to the microbiota studies or not?
Thank you for the question. We found huge patient data, so we did also find studies on the microbiome change. Until now, what they can tell that there are many factors that contribute to this change. Unfortunately, they cannot really tell. What I have seen is that the Shannon index, the diversity has been lowering, and regarding the relationship with IBD, I can tell that I have heard also from my supervisor that there are cases when there are cross-reactivity between the two diseases. So one can come from the other one.
Thank you very much. So one of the questions regarding microbiome was already asked. So the second question is about genetic risk. In the beginning, you have said about if you have included genetics as a possible risk for MC. So we are talking a lot about genomics and personalized treatment today. Also, we know that low bone density has some genetic involvement. So my question is, how do we stand for data for genetic risk in MC?
That's a very good question, thank you. However, until now, I did not find any studies that is related specifically due to the genetic testing or to the genetic mapping of these patients. And since we conducted a very large search, I can tell that I am sure that most of the studies that have been published until the updated search of us, I could see it. So until now, we do not have much data, and even the ethiopathology of the disease is not cleared up yet.
So we need more research on that.
Definitely.
Thank you.
Congratulations for this nice study. I particularly liked it because it's closer to my studies, in which we are focusing on drug effects on microbiome and on bile acids, and so that's pretty interesting. And I have several questions, but I will ask only two. The first is actually related to Professor Tantau's question. Do you think that microscopic colitis can affect or influence vitamin D absorption from the gut? And if yes, how big this influence can be? Because I think vitamin D mostly absorbs from the small intestine.
It's a very good question, thank you. I would say that it is a contributing factor, and maybe MC patients should be also tested as what is their calcium level and vitamin D level, even if they do not have osteopenia. So we know that for not even here in Hungary, we can receive nowadays enough vitamin D from natural sunlight. Therefore, the bare supplementation is also recommended, not for the patients, but also for general population. So in those cases where, let's say that the risk can be multiplied, so there is the chronic watery diarrhea, there is the inflammation, there is the malabsorption of this disease. I believe that this can take a huge contribution to the loss of vitamin D.
Okay, thank you. And my second question is, what can be the mechanism of action in the case of statins? So what do you think, how could they increase the risk of microscopic colitis? Is it a direct drug effect on the mucosa, or do they have effects on the microbiome, or what is your opinion?
Until now, what I have read, the theories are behind that they are down-regulating the TNF factors and up-regulating the pro-inflammatory interleukin-8. That is how, like the statins, that is how they can contribute to the inflammation in the gut. But also the microbiome changes have been also implicated in this matter. And I need to emphasize that we did not have many cases where multivariate analyses have been conducted in those studies. However, right in the case of statin, when they checked that what are the other factors, like taking into consideration the age factor of the patients, their sex, their other medications, their lifestyle, in that cases an adjusted odds ratio was not found to be increased.
Congratulations. I have a practical question. You clearly demonstrated that at the time of the diagnosis, they should perform a bone mineral density screening. It's a great result. But if it's normal, when should be the next examination should be? What do you recommend? In how many years or?
That's a very good question, thank you. Firstly, I would say that it depends on the patient characteristics, that what age they are, what is their sex, how is their lifestyle, how is their nutrition, are they smoking, are they taking alcohol, and so on. I would say that the repetition of the bone mineral density should be like in 2 years. That might be reasonable, of course, but if the risk factors accumulate, maybe a bit even earlier.
Okay, another practical question or something. You spoke about the statins and the correlation between the diseases. If you find a patient who's taking regularly statins, but the indication is not very strong, do you skip the medication, and what will happen? Will they change the disease, or maybe disease will disappear in some years? Who knows?
That's a very good question, thank you. We discussed a lot about this with my supervisor as well, and I can tell that we agree that statins should not be skipped, probably, because probably it's not the most or the highest contributing factor in those cases. Because, for example, the non-steroidal anti-inflammatory drugs, they can be replaced with other medications. However, in the case of statin, I believe we receive better outcomes for the patients if we leave it. And of course, if we can treat microscopic colitis with the correct therapy, which is budesonide, the gold standard therapy, in that case, maybe I would try first to treat the patients, and if they respond, like if we have clinical remission, in that case I would stick to the statins.
I have a short question regarding the therapy. In IBD we are using budesonide in a short term, that means 2-3 months, and we're living in a biological therapy era, and it's shown that anti-TNF can be even preventive regarding the low mineral bone density. If we look the therapy of MC, budesonide is for 6 or even 9 months, and if the patient is therapy refractory, we are using anti-TNF. What do you think? Could your results push the guideline to give for an osteoporotic patient with a new diagnosis of MC instead of budesonide anti-TNF in the first line?
That's a very good question, thank you. I believe here we should evaluate the benefit of these patients. For sure, the first line therapy is budesonide, and based on the guideline, only refractory cases it is used. I believe that should be first maybe tested, that what if we start from the beginning with the anti-TNF inhibitors, and in that case first we should screen the patients if they have osteopenia and osteoporosis. So I believe there are more steps until we get there that patients could benefit as first line therapy from biologics as having osteoporosis as well.
And do you know any results with vedolizumab? That's a gut-selective biologic.
Yes, vedolizumab is also used as in refractory cases, in budesonide refractory cases, since it is binding to the 4β7 protein surface. Unfortunately, we did not have data on those patients who had osteopenia and osteoporosis, treating them with vedolizumab or with biologics. They could evaluate the cumulative amount of budesonide, but not the newer therapies.
And my last question is if you plan any Hungarian registries?
That's a very good suggestion, and as I highlighted, we do need that. Yes, there is a plan. There should be make many steps, but one step by time, and we are focusing on that. Thank you.
Dr. Andrea Hános also has a question, our statistician.
Thank you. Congratulations for your thesis and presentation. Your thesis was very readable even for me, so I could read in it that the disease duration in case of your first study ranged between 2 and 163 months. So I think it could hardly influence your outcome and your results. And can you tell something about it and how it could be taken into account and how we can estimate the time in this case?
Thank you for the question. Yes, it's true. However, so we had 4 studies, but in all 4, the disease duration was different as well. So in that case, we cannot really tell that what is like the overall final suggestion here. However, at the different cases, what I have seen is that in some cases, since the disease duration was, as you mentioned, in that case they could evaluate the bone enzymes as well, like bone alkaline phosphatase and procollagen type 1, and that might be useful as well to follow these patients for their bone health.
And how can we just imagine a study? How can we estimate the effect of time? Do you have any idea if you have a registry or something?
Regarding what? Estimating the time?
The proportion of
the osteopenia and osteoporosis. So I would say that if we can screen them at the moment of diagnosis, even though if we screen them, we cannot really tell that since when the symptoms started. Because since it's underdiagnosed, since it might be that patients keeping it for themselves because they are ashamed of these symptoms, it may take months and years until we diagnose, first of all. And if we can diagnose correctly the disease, and after that we can screen the patients for bone mineral density, even in that time, I believe that until now, with all the knowledge that we have, we cannot really tell that what is the time perspective here.
Thank you. At this point, the audience can ask questions or make comments to the candidate. Yes, please.
Thank you for your fantastic presentation and your work in CTM. My question is regarding the statins and the NSAIDs. As was already said, do you maybe believe that this is a correlation and not a direct causation? And what I mean by that is maybe older people usually take more statins or NSAIDs, and this is why the odds are bigger, and it's not because it causes microscopic colitis?
Thank you for the question. It's an important point because even in the case of proton pump inhibitors and even in the case of non-steroidal anti-inflammatory drugs, we can tell that in those cases where we had histological controls, those also had like gastrointestinal symptoms. So first of all, that's why we think that this is the best scenario how we could make these comparisons. And in that case, we believe that these patients are more prone to take further medications or NSAIDs, or especially in the case of proton pump inhibitors, it is very interesting that since most of the patients have gastrointestinal symptoms, they are taking more proton pump inhibitors, and we believe that this might be one reason that in our study we did not find it to be significant. That is one mark. And on the second part, regarding NSAIDs and statins, it might be the case as well that in MC patients, there is a higher appearance of other autoimmune diseases, like, for example, rheumatoid arthritis. In that case, patients can also use non-steroidal anti-inflammatory drugs. So that might be the case as well, that these patients are more prone using this kind of drugs.
My question is related to the risk factors, why the women has such bad situation, especially the elderly ones, I suppose. And my second question is whether young ones do present this type of bad disease or not.
Thank you for the question. You mentioned that women are more prone to this disease. So there is change, but it's in a very late age. Around 80s, one of the subtypes of MC is more frequent among males. So lymphocytic colitis is more frequent around the age of 80s, but I would say that it might be the case that at that age they do not get the correct diagnosis either. And regarding your second point, there are child cases written down as well, especially in collagenous colitis. So there is a spread among all ages, I would say. However, nowadays I can tell that more cases are diagnosed in the elderly women population, but this might be also affected based on the underdiagnosed numbers.
Okay, thank you. Anybody for question? If not, thank you for presenting your thesis and answering our barrage of questions. Now the evaluation committee has to withdraw for a 5 minutes evaluation. Dear candidate, dear audience, committee, I'm glad to announce that all members of the evaluation committee scored the maximum for you, So the average is 5 again, with no standard error of mean. And this is the highest possible 100%, and congratulations for that.
Thank you.
This excellent result is in a complete harmony with the outstanding achievements of late and recent PhD students of the Center for Translational Medicine at the Semmelweis University. So maybe I pass you the final talk.
Thank you very much. Thank you for your evaluation. Thank you for your time, and thank you for your patience and attention to my underdiagnosed and very slightly discussed topic. And thank you for all the support from the CTM, and thank you for being here, everyone who I am working with, and my friends. And thank you, my family, that you traveled here and attended this magnificent moment together with us. Thank you.